Welcome, everyone, to the last part of our glaucoma series, and there is no one better to close out this incredible series than Dr. DeBry. My name is Dr. Stephanie Wu, and I am your host for this evening, and I am also the founder of Wu University. It's now my pleasure to introduce our speaker for tonight, Dr. Peter DeBry. Dr. DeBry attended the University of Utah for medical school. Then he went to the University of Wisconsin for his residency. After that, he went to Bascom Palmer Eye Institute, and that is in Florida, one of the top eye institutes in the nation, to complete his fellowship. Then he was an associate clinical professor at the University of Missouri, Kansas City, and relocated to Las Vegas in 2003. And that's actually where I met Dr. DeBry, is when I was a intern. My very first internship, I was with Dr. DeBry. So I personally got to see Dr. DeBry in action, and I got to observe lots of surgeries. And I can tell you that Dr. DeBry is a wonderful surgeon. He's a wonderful doctor, and he's very talented. There would be days where I would go in and he would be doing a corneal transplant. And then the next patient, he was doing a trabeculectomy. And then the next patient, he was doing cataract surgery and all sorts of fun things. So we are very lucky to have Dr. DeBry educating us this evening on glaucoma. Thank you, Dr. DeBry.
Okay, great. Thank you, Stephanie. I appreciate that introduction. It was always fun having you around, and I've enjoyed watching your career. That's wonderful. You have these Stephanie Wu University events. They're terrific events. Tonight, I'm going to talk a little bit about eye drop and glaucoma medication compliance and adherence. I always like to start with a case presentation first. So this is a patient who came in for evaluation due to elevated eye pressures. That's where a lot of our patients come from. She was 63 years old, and she failed her screening visual field test with her optometrist. She had a history of breast cancer and was taking tamoxifen, but one of her complaints was she was having trouble reading, and she actually had to take her finger and move it along the words to help her to see what she was looking at. So her acuity was terrific, 20/25 and 20/20. She had full motility, normal pupils, slightly elevated pressures. That's what brought this to the attention of the optometrist. And when you looked at her eye, everything in the anterior segment was very healthy and very normal. Here's her fundus photo, and hopefully you can see the details of that fairly well. Nice, healthy nerve, well-defined borders. And one thing that I really like to look at is the nerve fiber layer. So when you can almost ignore the appearance of the nerve and see if the nerve fiber layer is healthy. And here you can see, nice color and shading to the nerve fiber layer, indicating that this is a very healthy nerve and retina. Same story on the other eye, a very good, healthy looking nerve. This was the visual field in the right eye, very healthy and good. But when you looked at the visual field for the left eye, there was this nasal defect, superior and inferior nasal. And it did, in some respects, it did respect the midline, which is kind of suspicious of a neurological condition. Sometimes glaucoma can do that, but a lot of times we think of neuro conditions. So our diagnosis for this lady was ocular hypertension because her pressures were slightly elevated. She had a visual field defect, but when we looked at the nerve, the visual field defect did not match the nerve or the nerve fiber layer. So we really don't think this is a glaucoma condition. But because of the ocular hypertension, we wanted her to come back, get her further testing to get the baselines. So I went home and did some research to see what are the things that could be causing these findings for this patient. And tamoxifen that she was on for her breast cancer treatment has documentation of ocular toxicity. And it's a reasonable incidence, 6 to 12% in that range. And there's actually several things it can do. Intraretinal deposition, macular edema, corneal opacities, kind of like verticillata. They can get a posterior subcapsular cataract, optic neuritis, and decrease in the EOG. So there's kind of a long list. None of these things really mentioned visual field defects, so it didn't seem like the tamoxifen was part of that. So she came back for her follow-up testing and a pressure check. Her pressure was a few points better. That's always something interesting in glaucoma care. You can see one patient at 8 o'clock in the morning one day and have them back at 4 o'clock in the afternoon on another day. Their pressure can vary by 3 or 4 points during those two different readings. Her PAX was slightly thin, around 500. So if her pressures were slightly elevated, that would be a little bit more concerning, and we would want to watch that a little more closely. So we did a visual field. A lot of times if I have an abnormal field, I will like to repeat that within a few months just to see if it was a repeatable defect. And here's what we got this time. The right eye, which was perfectly normal the first round, is now starting to show some very minor temporal defects. And then the left eye has that fairly deep nasal defect, still respecting the nasal midline. So our assessment plan for this visit: ocular hypertension. Her pressure was a little bit better, but her cornea was slightly thin. And then evidence of a homonymous but incongruous visual field defect. So with this story, we definitely wanted to get an MRI to see if there's evidence of any neurological conditions happening. So here we see the axial cut with the flare sequences, several little white spots that are showing up in the area of the brain. And I have a normal one on the left comparing to her abnormal one on the right. And here's the sagittal flare sequences. You can see those little white spots. Those are enhancing areas that we typically see with demyelinating conditions like multiple sclerosis. But you can also see that the brain is kind of shrinking away. A lot of the substance of the brain is missing. So there's degeneration of the brain fibers. So with this assessment, we now have a diagnosis of a demyelinating condition. And so we're going to refer this patient to a neurologist for further workup. And then we also have, from our perspective, the ocular hypertension. Just a couple comments on ocular hypertension, because two common options are to do treatment or follow without treatment. And if you're going to do no treatment, then there's several must-haves that you need to be aware of. Number one, you need a patient who is aware and understands the situation. They're willing to come in for all their follow-up visits. If they disappear for 5 years and never come back, then obviously we have a problem. We want to make sure we can get accurate pressure readings. So if they have something abnormal with their cornea or another reason to not have good pressure readings, then it's not safe to monitor them without treatment. It's most helpful if they have clear media. That way we can get good photos and good OCTs. It helps if they're a good, consistent visual field taker. And then IOP, I usually use a cutoff in the upper 20s. If they start to get up into the 30s, I start to get concerned, especially risks of CRVO somewhat increase when your pressures are high. Even if the nerve's not getting damaged, there can be other issues that happen. So if they're in the low to mid 20s, I'm usually happy to monitor them without treatment. If they start to get in the upper 20s or obviously in the 30s, then we typically are looking at treatment. So in this lady's story, she had visual field abnormalities. It's difficult to follow somebody for the possible development of glaucoma if they already have a visual field that's abnormal. And so therefore, I didn't feel confident or comfortable monitoring her without treatment and opted to put her on some medications. So we started her on some latanoprost. When we started that, her pressures came down nicely and her ocular hypertension was under good control. So this is very interesting, though, to see the sequence of what happened with her visual field test over the next several years. A small defect grew to a larger defect, which eventually grew to almost an all-encompassing decreased sensitivity of the visual field. And this is the right eye. And then you can see the same pattern developing in the left eye. And it was much more much more congruous as it developed compared to those very first fields. So discussing this with the neurologist, this lady actually had two issues. She had multiple sclerosis. That was the demyelinating aspect of her MRI. But she also had the degeneration of her occipital cortex. So this is in the category of posterior cortical atrophy, which is a variant of Alzheimer's disease. And I didn't know a lot about this, so I kind of read up on it to understand what was happening for this lady. This posterior cortical atrophy is also called Benson's disease. It's a atypical variant of Alzheimer's where you get atrophy of the posterior cerebral cortex, which is going to affect the vision and also the visual processing centers. Normal Alzheimer's is mostly affects the memory, language, and perception. When these people have the posterior variant, their memory actually seems to be pretty well preserved, as does their language, but they have the decline in their visual aspects and then the literacy skills of visual processing. So in her story, she had to use her finger to help her as she was reading. And so this was part of this posterior atrophy aspect of her Alzheimer's condition. And you can see how quickly her vision went downhill. It was kind of scary to see. Within several years, she had almost complete wipeout of her visual field. The PCA variant also can come at an earlier age than typical Alzheimer's. So these people can be affected in their mid-50s and even their early 60s. So when you look at those visual fields, it was kind of a reminder of the utility of visual field testing. We were talking about this with one of my technician training things that we do on Friday mornings, and discussing kind of the toolbox of the different tests that we have for assessing the eye and assessing the visual field. And an OCT is a very focal measurement. It's measuring the nerve fiber layer, or it's measuring the retinal aspects of the macula. It's a very focused anatomical test. The visual field, since it's a functional test, is very unique in that it's covering the entire visual system, all the way from the cornea to the occipital cortex. And then the distribution of the defect will give us a clue regarding the location. So if we have a bitemporal defect, we know that's in the area of the chiasm. If we have a left or right homonymous defect, we know that's back in the occipital cortex. If we have something that's inferior only in one eye, we know that's either the nerve or maybe a retinal detachment. If there's an arcuate defect, then we know that that's glaucoma, or could be an AION. And then if it's a cataract or a cloudy cornea, things like that, we're going to get decreased sensitivity of the entire field. So you don't typically get focal defects with more anterior pathology. But you can see from the cornea all the way back to the occipital cortex, the visual field is helping us to have information about their vision. Okay, so on to our main discussion. And again, if you have questions, you can add them into the Q&A, and we will address them at the end of the talk. So as I've gone through my career, I've started to really have a better picture of the roadblocks that stand in the way of patient care. And I would say 30% of my patients every day have some aspect of their care that there's a problem. We sent in a prescription, but their formulary doesn't include that medication. And so the patient didn't get their prescription filled. We said, come back in 3 months, but then their insurance changed and they came back a year later. We said, when you come back, you need a visual field test. Also, you need dilation. And then they come back and they said, oh, I forgot to have a driver with me, so I can't do that. And my neck hurts today, so I can't do a visual field test. And it's just amazing to me to see day after day, patient after patient, the high percentage of patients who aren't doing what they're supposed to do. And this does have an impact on their care. It has an impact on their vision. Unfortunately, with COVID, we've also seen the same thing where patients have disappeared for a year. They stopped taking their medications, and now here they are coming back a year later. Their pressure is 30, their visual field's worse, and they say, I couldn't get into you, but I know that's not true because we've been working every day since COVID started. So these are people who are choosing to not come in. So it's a frustrating thing to see, and it really it's a challenge taking care of these patients under these circumstances. So the way I describe it to my staff is we live and we work in chaos. So this healthcare system is chaos. It's chaos because patients don't understand it. They don't know about their copays and deductibles. They don't know about what's on their formulary. They don't know about how medications work or how they use them. And then we have insurance companies that don't help the situation at all. Insurance companies want their people under their plans to be somewhat confused and not use their plans. So really, every day that we come to work, our goal is to manage the chaos and help patients to get better care. And it's a big challenge of it in the things that we face. So tonight we're going to talk about patient adherence, just one small aspect of this chaos, and how do we improve patient care. And when you think about it, we have a great medical system. We have good insurance plans. Almost all of our patients now can get covered on Medicare or Medicaid. We have effective medications that are reasonably cheap because most of them are generics. We have great surgeries that work. But even with all of these things available, there's still some patients who lose vision. And this is really a result of poor adherence to their therapy or just not coming in when they needed to have care. So I guess poor adherence to medical visits is part of it. You see a patient and they come in with a pressure of 30 and their vision is down in one eye. And you talk to them and find out, when did you start to notice your vision was worse? Oh, 3 months ago, I woke up and my vision seemed a little foggy. How come it took you 3 months to come in and get your eyes checked? So that's what happens. Okay, so this was one of my patients from a few years ago. It was a 48-year-old African-American. Let's say his nerves are a 0.9. He's taken a couple of eye drops. The last few visits, his pressure was good, 14, but today he comes in and his pressure is 24. And my techs all know that they're supposed to ask about compliance, ask about who puts in their eye drops, ask about refills and copays. But the note from the technician said this patient used his drops appropriately in the last 24 hours. So now you have a plan. This patient, he seemed like his glaucoma was good, but now things are getting more out of control. So what's our plan? Number one, we could add more medicines. Number two, we could plan a laser like SLT. Number three, we can do a surgery like trabeculectomy. Or number four, review compliance and importance of drop use and have the patient come back in 3 weeks to have them checked again. So in this case, we opted for number four and had a chat with the patient like, hey, what's really been happening here? The true story that the technician didn't get was that the patient ran out of their drops a week ago. They needed some refills to get back on their medicines. We had them come back a few weeks later, taking their medicines, and guess what? Their pressure was back down to 14. So when you take your medicines, your pressure stays good and this stays controlled. But some patients just don't bring that up, like they feel uncomfortable. They feel like we're going to judge them. And so they don't tell the whole story unless you really kind of tease it out from them. And early on in my fellowship, I did a little study where we took patients who were on 3 medicines and we stopped one of the 3 medicines, just randomly picked one of the 3, and then had the patient come back a few weeks later to see what their pressures were. And an amazing percentage of them had pressures that did not get significantly worse by stopping a medication. And what that was telling me was that a lot of people end up getting over-medicated because this exact scenario. They come in one day, their pressure's up 2 or 3 points. The doctor says, oh, let's just start you on another medicine. And you can add 2 medicines, 3 medicines. And unfortunately, that leads to worse compliance. It leads to worse kind of side effects and symptoms. And in many cases, it really doesn't make the pressures get better. So the real story is that patients are not truthful unless we really try to get the truth out of them. But if you want to do that, you have to take time and you have to kind of build bridges with patients. You have to get to know them so that they trust you. And then they'll be willing to kind of share their stories and tell you more about it. So if you don't have that full truth, you're going to make bad decisions. So you may do an SLT laser and really of no benefit or no utility for that patient. Or even worse, if you decide to do a trabeculectomy or something more invasive, then you're putting the patient at risk that they didn't need to be at. So, why are we talking about this now? Well, for me, it's my midlife crisis. After taking care of glaucoma patients for 20 years, you start to see patients who, despite all of your best efforts, they're getting worse year after year after year. Why are they getting worse? Am I a bad doctor? Are they bad patients? What's happening? I don't have a Ferrari yet. I haven't made that part of my midlife crisis. But it really is, it seems like Groundhog Day, because every day you wake up and you go take care of these patients and you just hear the same story every day of patients not doing what they're supposed to do. So you start shaking your head like, what can I do differently so that I don't come to work every day and face these exact same scenarios? How can I make patient care better so that patients are doing what they're supposed to do? Well, number one, I need to understand compliance myself. I need to understand the whole situation and the kind of the science behind it. Number two, I need to take that science and I need to act to make things different in my office. How do we process patients through the office? And then number three, we need to act nationally to try to improve the healthcare system. And later on in the talk, we'll kind of talk about some of those options. So medication adherence is the degree to which the person's behavior corresponds with the agreed recommendations from a healthcare provider. So you're a healthcare provider, you're telling the patient what you want them to do. The patient acknowledges you and seems to understand you. If they go home and don't do what you told them to do, then they are not having good adherence. So non-adherence can take a variety of different forms. Like we were talking about in my clinic, lots of different things can happen. You can give a prescription and the patient doesn't fill the prescription. They can take an incorrect dose. They can take the medication at the wrong time, forget to take their doses, or stop therapy too soon. And what does the data show? Well, you heard about my life. I'm sure you've all experienced the same thing. Every day we have patients who don't do what they're supposed to do. But in national studies of chronic diseases, 50% of our patients don't take the medications appropriately. So when I see 60 patients in a day, honestly, I assume that all 60 of them are doing what they're supposed to do. But if you really dig in and understand the data, the reality is probably half of them are not using their medications the way that they're supposed to. This is just a general graph that kind of shows what happens throughout the process of having a prescription given to you. If you give a prescription to 100 people, only 88% are actually going to get that to the pharmacy and fill the medication appropriately. Only 76% are actually going to take it on a regular basis. And only 47% are going to get multiple refills and continue to use that medication. So you can see 50% is a sad number, but it's the fairly consistent reality. So one of the chronic diseases that's been studied a fair amount is related to heart disease and the use of statins to control cholesterol. The way that they measure this in healthcare settings is the proportion of days covered. So if you went to the pharmacy and filled your prescription, you got 30 days worth of medicines. What percent of those days did you actually use what you're supposed to use? So the kind of the cutoff of what they consider as reasonable is an 80% proportion of days covered. So when you think about that, like for glaucoma, if 20% of the time your pressures were high, you can imagine that you'd have a fairly high chance of having your disease get worse. I'm not sure how that really compares to heart disease and other things, but when they did these measurements within 3 months of starting therapy, the proportion of days covered had decreased to 79%. So it was already hit the threshold of suboptimal adherence in this population. After 3 months, 40% of patients had suboptimal adherence, and after a year, 61% of patients had used their medications less than 80% of the time. So you'd think if you had a heart attack or you had chest pain, that it would remind you like, oh, you should use your medications. So they looked at these populations. Acute coronary syndrome are people who have chest pain when they walk upstairs. Chronic coronary artery disease are people who have had a blockage and their doctors talk to them about it. Primary prevention is somebody who has high cholesterol, but no heart disease yet, and they're taking medications to try to prevent heart disease. So if you look at these different conditions and you look at patients after 2 years of being prescribed a medication, only 40% of patients are continually refilling their prescription after 2 years. And these are people who have chest pain, like they walk upstairs and their chest hurts, yet only 40% of them are using their medications consistently. People who have heart disease but no chest pain, only 36% of people are using them. And primary prevention, 24% of people are continually refilling their medicines 2 years later. So you can see how poor that is, what a low percentage that is. And I've experienced the same thing with glaucoma. So the more advanced patient who has hand motions vision in one eye, they have a 0.9 cup in the other eye. They've had glaucoma surgery in the past. They moved from Chicago to come to Las Vegas, and then they go for a year without using their medication. And then they finally come to see me and they're like, oh yeah, I've been out of my medicines for a year. I guess I need to get started on my medicines. So these are people who are symptomatic, already lost meaningful vision from glaucoma, and they don't even realize that a year is so long and so dangerous in terms of not using their medications. You can see that even people who know they have a disease oftentimes don't follow the way that they're supposed to. So here's some examples of chronic medical conditions. A condition that requires daily medication, day after day, month after month, year after year. Most people are good. If they have a cold, a sinus infection, a headache, they'll go take a pill. They'll use it for a few days and they do really well with that. But when you tell somebody you have to take this pill or this eye drop every day of your life for the next 30 years, that can be a little more daunting for people. So chronic diseases like hypertension, asthma, HIV, depression, these are some of the diseases that have been studied to see how adherence affects the outcome of the disease. So glaucoma obviously is very similar in a lot of these ways. It's a chronic disease. It has minimal symptoms, especially early on in the disease. And it does require continued care and regular follow-ups. So we know that glaucoma patients echo the same findings in diabetes, high blood pressure, other things, that they really do have a high rate of poor adherence. And the main risk for vision loss in glaucoma is related to the pressure. And obviously that's directly related to medication adherence. If you're not taking your medication, your pressure goes up. It's amazing. Even 6 hours later, with skipping a dose, patients don't realize that their pressure is already going up. So the medications don't have a long half-life. So why does adherence matter? And this is an amazing statistic. Of all medication-related hospital admissions, 33 to 69% are due to poor medication adherence, with the resultant cost of $100 billion a year. So if patients do what they're supposed to do, they don't end up coming to the hospital. If they don't do what they're supposed to do, their conditions worsen, or they get side effects or other problems. They come to the emergency room at 2 o'clock in the morning, and that requires lots of care that's very expensive. Trips to the hospital, admissions to the hospital. The results of the failure to adhere, poor health outcomes, increased costs, decreased quality of life, and even death is a possible outcome for many of these chronic diseases. So this is the amazing thing. Like, we live in America. We have great technology. We have great healthcare. Why does any person who lives in America lose vision from diabetic retinopathy? Why does anybody who lives in America lose vision from glaucoma? Like, we have the ability to stop these diseases. And the fact that people lose their vision is because they're not doing what they're supposed to do. So it's people's lifestyle and their choices that they make and their bad decisions that cause them to have their problems. If you have diabetes, you can't have a 32-ounce Coke when you go out to eat for lunch. And if you do, day after day, year after year, you're going to have kidney disease, you're going to have eye disease, you're going to lose your vision. So poor lifestyle, bad decisions is what leads to poor outcomes. So here's another slide that talks about statin adherence. So looking at 3 possible outcomes, which is cardiovascular death, non-fatal MI, or the need for revascularization, like a catheter and stent placement. So they looked at the entire group of people, and then they pulled out people who were more compliant and compared them to the entire group. So for cardiovascular death, there was a rate of 32%. If you were very compliant with your therapy, the rate was decreased at 37%. On a non-fatal heart attack, for the entire cohort was 31%. If you were one of the better patients and you were more compliant, it was decreased at 38%. And then the need for revascularization was 37% in the entire group. But if you looked at the compliant patients only, they had a lower risk at 46%. So this is well-defined outcomes that show if you're compliant with your treatment, your health outcomes are better. I wish we had this for glaucoma where we could show the same thing, because I'm sure we'd see the exact same picture. So the other slide mentioned a little bit about how costs are increased when patients don't do what they're supposed to do. So these are hypertensive patients, high blood pressure, and the annual cost that it is to take care of them. This is probably from the Medicare databases. So people who received their high blood pressure medication and were compliant based on the refill data had an annual cost of $4,850 to take care of them. If they purchased some, but were not getting refills as regularly, the cost of taking care of them was $6,400 for a year. People who took their medications very irregularly and didn't purchase them regularly had a double the cost of taking care of them. So when you take your medications, you are healthier and you have less trips to the hospital. And in general, it costs less to take care of you. One trip to the hospital because of chest pain is probably a $20,000 event right there. So why don't patients do what they're supposed to do? We kind of talked about those lifestyle choices, but there are other factors as well. Therapies that are somewhat complex can throw patients off. Side effects. If you have a headache and you take a Tylenol, it makes you feel better. If you have diabetes and you take a diabetes pill, sometimes it makes you feel worse. Same thing with glaucoma eye drops. They can make your eye red, they can make it burn, they can make it feel tired or irritated. So people have kind of a negative incentive just right from the start to not take those regularly. A failure to understand the need for the medicine. So this is kind of their literacy or their understanding of it. And then high out-of-pocket costs is another big barrier for a lot of people. If it's a difference between eating groceries that week or buying your medication, then people will choose to have their groceries. So as far as the complexity of therapy goes, if you have a patient on a single medicine, they're taking Timolol once a day or they're taking latanoprost once a day, and you simply add a second medication. Let's say they came in, their pressure is 21, your target's 14. So you add Timolol or you add dorzolamide Timolol to their therapy. The studies show that their adherence to the first medication goes down. So you would think after 2 or 3 years of taking one eye drop, you'd be in a pretty good habit and you'd know how to use it and you'd put it in every day. And then adding a second drop, maybe the second drop would have problems, but why would that make you have problems taking the first drop? And the studies show that just adding on that second medication, for some reason, makes their adherence to even the first medication decrease. So even something as simple that we would think as 2 different eye drops can be difficult for some patients. Now, if you take some patients who have high blood pressure, diabetes, kidney disease, and glaucoma, they're taking 6, 8, or 10 medications. That can be very difficult for some people. So medication costs is a big factor as well. When they looked at these studies on adherence to statin therapy, they were definitely not optimal, even in patients who had great coverage. But if you take those patients and you changed their copay policy or their coinsurance, then their compliance decreased. And when you look at those cost slides where you see you're doubling the cost of taking care of somebody from $4,000 or $5,000 a year to $10,000 a year just by making sure that they're compliant, it makes you wonder why would an insurance company charge a copay for a medication that only costs $50 or $60 a month, when you know that if that patient takes that medicine, it's going to cost you $10,000 less that year taking care of that patient. So when you think of it from that perspective, it's like, why don't we just give away the generic drugs that help people to be more healthy. Like our medical system would be in better shape if we didn't have copays for most of these medications. Okay, so health literacy is a measure of a patient's ability to understand the disease process and the complex issues related to disease treatment. So this is a classic video from a TV show called Swamp People. And as you watch this, just think of the people who come to your office every day. Do some of them fit into this category? So we're going to watch just like a two-minute clip of this little video here.
Starting with new help's always a challenge.
You know, having new help it's not hard to get used to the new help, but it's hard to get them to work the way you want them to work. I can't change for my helper. My helper got to change for me.
Troy's always joking around with his crew, and on his boat, he says what he wants. So true to form, he begins to tease Liz right off the bat.
Right, Elizabeth?
What I told you about calling me Elizabeth.
But what's wrong with Elizabeth? That's not your name.
I thought it was going to be Liz or T-Liz. The only person that used to call me Elizabeth was my mom when she'd get mad at me. Elizabeth Ann, come here.
All right, T-Liz.
Yeah, that's better.
She don't like me to call her Elizabeth, but I kind of call her what I feel like calling her. Hold on, Elizabeth. I'm down and on, Elizabeth.
What I tell you about that, Troy?
I thought you told me to call you Elizabeth.
I asked him nicely, look, don't call me Elizabeth, call me Liz. Well, that was his ticket right there to pick at me even more.
Come on, Elizabeth Ann. Tighten up. I dig it.
Liz knows that if she doesn't fight back, it's going to be a long day.
Troy, if you call me Elizabeth one more time, I'm gonna freaking bust your ass.
Oh. All right, little T-body lady.
On Troy's boat, showing some backbone earns his respect.
Let's see, I always wanted to learn how to throw one of these things.
Go ahead, God. Give me your best shot.
Yeah.
Okay, so it's interesting that that's American TV for you. So, but just think that these people are in your office every day. Sometimes I go home at night and sitting around the dinner table and chatting with my family. It's amazing to me that the group of people you see is a slice through American life, and you have people from all aspects of culture out there. People who really are PhDs and accountants and engineers, but then you have people like you just saw in that video who didn't even graduate from high school. They have a poor understanding of medications, of medicines, of diseases. If this happens to me regularly. So again, a patient who had a cornea transplant and they come back 3 months later. No, actually, here's the scenario that happens. You do a surgery and then they're on their pred. I usually do it four or five times a day for the first few months. They disappear after the 6-week follow-up, and then we don't see them back for 3 months. And they were supposed to come in, but they didn't come in for their follow-ups. And then they say to you, oh, yeah, I ran out of that steroid eye drop and my dog ate it. I lost it, whatever happened. And they haven't been on steroid now for 4 or 5 weeks. They haven't come in for their follow-up visits. You look at their cornea, it's already failing. And you're thinking, this was like a $7,000 surgery that we did for you. And this was a treasured gift of somebody who passed away that you were able to have their cornea. And this is your understanding and the way that you treat it. So if a patient really understood the gift that it was to have a cornea transplant, they would come in for their visits, they would take their medications. So how do we combat this when people need to come in, need to do medications and do things, but they don't? So number one, all of your communication needs to be at a 5th grade level. And after I learned about this, I went back to all of my papers, everything that I ever typed up, and I tried to make them as simple as possible. So for us, it's hard to connect with people on a 5th grade level. we've been through years and years and years of school. We tend to be more scientifically oriented. So we are functioning higher than a 12th grade level, and we have to communicate with people on a 5th grade level. So you really have to focus on ways to do that. And then if you can have handouts to give to patients, then at least if you said something that didn't fully make sense to them, but you give them the handout that's based on the 5th grade level, they can at least go home and read it and understand it better. Every single one of my patients who leaves my office leaves with a medication chart. If I start a medication, and even if it's latanoprost once at night, I write it on the chart and I give it to them. Especially if they're taking more than one medications, they all get that chart. When patients come in as a new patient, I have a glaucoma book that I give them. I have things on narrow angles. I have things on glaucoma suspect. And again, I try to write them to a 5th grade level. Whether I was successful or not, at least it's something that the patients can read through and write down questions if they have them. So just imagine, like, if every wall in your office had some messaging for patients to help them to be a better patient. Like, how do you teach a patient to be a better patient? The nice thing with glaucoma patients, they come in over and over and over again. So we get to know them. They have a chance to be in our office. So if we put posters around our office, then we can help with the messaging and help them know what they're supposed to do. So here's my quality poster. If you lived with Marcia and Greg, you would want to use Xanax every day, just like me. Okay, so if we spend time and invest in methods to give better medication adherence, can we impact patient care and the cost of patient care? So we showed you other slides that showed that when patients aren't adherent, that it costs more to take care of them. Now, what if we now do an intervention? Can we show that intervention helps make it better? So here's healthcare expenditures related to diabetes medication. So there are medical dollars and prescription dollars. So a medical dollar would be if you went to the doctor for a visit, if you went to the emergency room, if you went to, if you had a CT scan, those would be the medical dollars. The RX dollars are the insulin or oral medication that's used for your diabetes. So if your adherence was very high, this would be on the right side of this chart, then you are spending more on your medicines because you're taking your insulin and you're using needles and you're taking your oral diabetes medications. So your refills, you'd have more refills and you spend more on your medications, but your total cost of your medical care is dramatically lower. So here, $3,800 for medical costs, $700 of prescription medications. If you go all the way to the left of this graph, you can see a diabetes patient who never took their medications, who didn't do anything they were supposed to do. The cost of taking care of them was almost 3 times higher, almost $9,000 to take care of this patient in a year compared to the patient who took their medications. So you can see adherence and compliance has a major measurable effect on patient care. So just think of the glaucoma the cost of glaucoma, right? So in that first scenario where the patient was taking a couple drops and then their pressure was high, and that now we give them another drop, they're taking 3 drops. Just think of the cost of additional drops or lasers or surgeries when it really was a compliance issue of why their pressure was high. So more than that, what's the society cost of taking care of a blind person compared to a person who has good vision? So when one person loses their vision, it takes the care of another person now out of society to help take care of them. Okay, so when you look at all these things, you've seen really good data. So now looking at it, who needs to change? Is it patients who need to change or doctors who need to change? Can we take that swamp person on the boat and can we turn them into somebody who's knowledgeable and has good compliance? Or do we need to fix the system of how we take care of these patients? So I've got a couple of great quotes here. So despite evidence to the contrary, there continues to be a tendency to focus on patient-related factors as the cause of adherence problems. to the relative neglect of provider and health system related determinants. So we, as doctors, we really want to blame patients when they don't do what they're supposed to do. Instead of looking at the system and the chaos and the craziness of the system, we look at the patient like, how come they didn't do what they were supposed to do? We want to blame it on the patients. So these latter factors make up the healthcare environment in which patients receive care and have a considerable effect on adherence. Interventions that target the relevant factors in the healthcare environment are urgently needed. So in other words, we don't need to fix the patients, we need to fix the system of how we take care of them. So from a glaucoma aspect, we need to look at every part of the patient care. How do we remind patients to come in? If a patient doesn't show for their appointment, what's the process of trying to track them down? Do we send them letters, emails? Do we send them certified letters? How are we communicating with our patients if they're not coming in? The cornea transplant patient who didn't show up for their 6-week visit, I want my office calling them. Like, you better get on the phone and call that person. Why didn't they come in? You have to be organized. You have to have a system in place, but it's our job to track down those patients. So we need to build a system that's so simple that even the swamp person is going to be able to do the therapy that they're supposed to do. That might mean free refills. It might mean having 20 refills per year instead of 6. You know, whatever it takes to make the things more simple. So there is growing evidence to suggest that because of the low rates of adherence, increasing the effectiveness of adherence interventions may have a far greater impact on the health of the population than any improvement in specific medical treatments. Now, this is amazing to me, because what do we hear about every day? We're hearing about the technology and the new things that are being developed, and new lasers, new procedures, new eye drops. Those things are all amazing, but this quote really highlights, like, you can invent the most amazing and best glaucoma treatments, but if they cost $10,000 and are very complicated and require prior authorization and require 6 visits, even though it's the best treatment ever, if a patient isn't adherent, then it's not going to work. So maybe the most important thing is that we focus on having patients do the very simple things they're supposed to do, and have less of a worry about the newer and high-tech and exciting things. So having adherence is the solution to having a great healthcare system. Now, obviously, we still like the exciting things. We're doctors, we're scientists. We want to see what's happening out there. We want new and better things for our patients. But this just highlights focusing on adherence is probably more important than all those things together. So from a glaucoma aspect, as I mentioned, one nice thing is that patients come in for several visits a year, maybe 2, maybe 3. So every time a patient comes in, we need to be taking a little extra time to review with them how to be a better glaucoma patient. So not just measuring their pressure, seeing what their visual field is, but actually taking some time to help them to be a better patient. So right now we focus on the medical care and not a lot on what or how to make them a better patient. We really need to flip-flop that. Let's spend more time with the patient education part and less focus on the other aspects. So every time I measure a patient's pressure, I like to say to them, or just review their eye drops, the reason you're taking this drop is to lower your pressure. The reason we want your pressure lower is to lower the risk of glaucoma damage happening in your eye. Please make sure you take your drops every day. They're very important to you. So just reviewing it over and over with patients. Asking open-ended questions is very, very important, because if you're a technician and you're working up a patient and you say, are you still taking Timolol and latanoprost? Then the patient's going to nod their head and say, yes, but the reality is they're not. So, but if you say to the patient, tell me about your medications, which ones are you using? And then say, tell me about, are there any times that you miss those during the week? So you can see if you ask those open-ended questions, patients have some time to think and some time to respond. As I mentioned, written instructions for every visit, super important. And then it's nice to have other resources. Like I mentioned, I have a glaucoma book. It has lots of details in it about glaucoma, but it also has other resources, some web addresses and other things for patients to go to. There are other things, like there are some phone apps to help people to use their medications, support groups for glaucoma where people can talk about it and compare their experiences. All these things can teach patients to be better patients. So nationally, what are we doing in terms of reimbursement and development for things for patient compliance? Like if I spend an extra 10 minutes and I give things to a patient, I'm basically wasting my time because I'm not getting paid any more for that visit. Yet we know from this information that it's the time that we spend with patients to help them to be better patients that makes them have more successful healthcare. So what are other things we can do in those areas? So wrapping things up, hopefully by now you're convinced patient adherence to therapy for chronic diseases is very poor. Health literacy is a major barrier to improved adherence. We can't change our patients. The swamp man today is always going to be the same next week, next month. He's not going to be different. So we have to change the system that patients go through to improve the way that they get their care. You, in your work, the things you every day need to be the leader in your office, recognizing how your patients are treated. I think this is a terrific discussion for primary care optometry because these people are coming into your office regularly as well. These patients have diabetes, they have high blood pressure, some of them have glaucoma, some of them have cornea transplants. They have reasons to take medications. You could just click boxes, do an exam, take pictures, or while you're doing these things, you can chat with them. Hey, how are you doing with those eye drops? Tell me about it. Do you use them regularly? Are there times that you forget? Do you get all the refills you need to get? How can I, as an optometrist, help you to be a better patient? Every patient who walks into your office, you have that opportunity.